Dear audience, I am very pleased to present you my 15 months progress in my PhD work. The topic of my PhD work is role of left atrial strain in neurocardiology. First, I would like to share some key information about myself. My name is Henriette Mészáros, and I work at the Heart and Vascular Centre of Semmelweis University as a PhD student and cardiology fellow since 2021. I can see in my everyday practice that the detection of atrial fibrillation requires expensive prolonged monitoring. So that is why derives my mission that with the help of my PhD study, I would like to decrease the necessity of prolonged monitoring. That's why I have two specific goals during my PhD work. The first is that I was aiming to investigate the baseline differences in left atrial deformation imaging parameters in patients developing atrial fibrillation in the future. I started this project 1.25 years ago. My second project aim is that we would like to assess the effect of high versus low mesh density device on left atrial strain in patients with patent foramen ovale. Here you can see the status of my first manuscript. I submitted this in the second journal, in the European Heart Journal Cardiovascular Imaging, after the first NAC exception. And it is a prestigious journal as well. So we are hoping to submit it as soon as possible in the near future. I would like to share with you some information about the background of my first project. As we all know, in the elderly, some comorbidities are developing, like left ventricular dysfunction, which can result throughout diastolic dysfunction to left atrial remodeling, which can cause atrial cardiomyopathy. Atrial cardiomyopathy can be the substrate for atrial fibrillation, which can result in cardioembolic stroke. Nowadays, the only gold standard method for diagnosing atrial fibrillation is prolonged ECG monitoring. But because of the healthcare costs, it is very expensive, and despite the broadening spectrum of smart monitoring devices, there is still no consensus on the appropriate modality and duration. So that is why derives our idea that we could and should implement a non-invasive yet sensitive method for assessing left atrial remodeling in practice. It could be the left atrial strain analysis using two-dimensional speckle tracking echocardiography, which could predict the occurrence of atrial fibrillation. So practically our aim is to limit the range of patients who need prolonged ECG monitoring. Our clinical question is the decreased left atrial strain associated with the occurrence of atrial fibrillation? We were looking for papers where cardiology patients were investigated who had two-dimensional speckle tracking echocardiography exam, and after it, a left atrial strain analysis. We would like to compare patients with detected atrial fibrillation during follow-up and without detected atrial fibrillation during follow-up regarding left atrial strain parameters, mainly global longitudinal atrial strain and left atrial contraction strain rate. And our hypothesis was that patients with future atrial fibrillation have decreased left atrial strain in sinus rhythm at the baseline screening. Here you can see the flowchart of our selection. At the end, we had 6 eligible full tests. Now I would like to speak about my results. And the first outcome was global longitudinal atrial strain. As you can see here, here is a transthoracic echocardiography examination, a 4-chamber view. And you can see here the speckle tracking echocardiography software working. It countered the left atrium, and the global longitudinal atrial strain, the tangential strain measured throughout the left atrium. Here you can see that for this analysis, we had 5 eligible full tests. And at the end, we could see that patients at the baseline screening in sinus rhythm who developed atrial fibrillation during the follow-up period had significantly lower left atrial strain, global longitudinal atrial strain, already in sinus rhythm compared to patients who did not develop atrial fibrillation during follow-up. So these changes were already present in sinus rhythm. Our second outcome was a left atrial contraction strain rate. It presents the left atrial function during the contraction phase. Here we had 3 eligible full tests for a quantitative analysis. At the end, we could see here also that patients who developed atrial fibrillation during follow-up had already in sinus rhythm a significantly decreased left atrial contraction strain rate. Now I would like to speak about the strengths and limitations of my work. Undeniable strengths is that this topic is very novel because it's the first meta-analysis which highlights the importance of this promising diagnostic tool. But based on the nature of this study, it is a meta-analysis. There are quite many limitations occurring. Like there was no uniform data reporting because of the differing studies. There were different monitoring methods used for atrial fibrillation detection. So in one study there was 24 hours Holter monitoring, in another 3-day Holter monitoring, in another symptom-driven monitoring, in another smart devices. So it was very heterogeneous. We should also mention age heterogeneity because we know that strain values are decreasing by age. And of course, because of the novelty of the topic, we had low number of studies eligible for the analysis. As a summary, John, I would like to emphasize some implications for practice and, of course, huge implications for future research. Based on our results, we could select patients who need prolonged heart rhythm monitoring and who need anticoagulation immediately. But before doing this, we should determine cutoff values of left atrial strain parameters regarding the necessity of prolonged heart rhythm monitoring and anticoagulation. For the determination of cutoff values, we still need some big randomized trials in the near future to fulfill this. As a conclusion, we can state that there are significantly reduced left atrial strain parameters in those with atrial fibrillation already in sinus rhythm. Now I would like to come to my second project, in which we are aiming to investigate the effect of high versus low mesh density device on left atrial strain in patients with patent foramen ovale. We planned to write a protocol of a two-arm randomized non-blinded single-center trial. As a quick background review, I would like to tell you that almost half of all cryogenic strokes are related to patent foramen ovale. And after the results of the big randomized trials, like closed trial in 2017, PFO closure seems to be superior to antiplatelet therapy only as a secondary prevention method for ischemic strokes related to PFO. But we also know that in the first 2 months after the closure, the incidence of atrial fibrillation increases. So it is suspicious that both electrophysiological and mechanical changes can occur in the atria. And after thorough literature analysis, we could see that there is no recommendation regarding the PFO device type. So to fill this knowledge gap, we aim to compare the two different mesh density types, high and low, of closure devices regarding electrophysiological and mechanical changes in the atria. Here you can see the procedure of the PFO closure. We are using the right femoral vein as an access point, and we are leading the catheter and the wire throughout the patent foramen ovale into the left atrium, and we are closing this patent foramen ovale with a special two-sided closure device. Our clinical question is, does the high mesh density PFO closure device decrease more left atrial strain and thus increase the risk of atrial fibrillation compared to low mesh density PFO closure device? Our inclusion criteria was that we would like to deal with patients over 18 years who were referred to a neurocardiology work group for PFO closure. We would like to compare PFO closure with high and low mesh density device regarding changing left atrial strain as a primary outcome and the atrial fibrillation as a secondary outcome. And of course, we have a huge clinical and research implication. We would like to achieve decreasement in postoperative atrial fibrillation based on the best device selection. We plan to have two arms, low mesh density and high mesh density device, and also a control group who would be cryogenic stroke patients referred to our neurocardiology lab but not eligible for PFO closure for some reasons. Here you can see the primary outcome, as I already mentioned, the left atrial strain parameters, and as secondary outcomes, atrial fibrillation and recurrent stroke. Here you can see that I finished the protocol drafting and the sample size calculation. Thank you very much for your attention. I would like to end my presentation with one of my favorite quotes. Do not let fear keep you quiet. Whatever it takes, find your voice, and when you do, feel the silence. Thank you.